Chris works at the World Health Organization, where he's a medical officer on the Medicines Access and Rational Use Program. He is also Secretary of the Expert Committee on the Selection and Use of Essential Medicines. We're particularly grateful also to Chris because our final scheduled speaker, Calypso Chakidu, unfortunately cannot be here today for understandable reasons, but Chris has kindly agreed to cover some of her slides as well. So we're going to give Chris just a little bit of extra time to cover both sets of materials. So Chris, welcome, and thank you for your generosity and also covering for Calypso. Over to you.
Thank you very much. Can you hear me at the back?
It might be on mute.
Is it?
Yeah, just move it up here 20 minutes. That's it.
Okay. Right. Well, we've been given 10 minutes, and I'm just wondering, how do I manage 35 years in 10 minutes? But let us see whether we can succeed quickly. I'm going to talk on the perspective of essential medicines, what the WHO has as its flagships in medicines, and what are the implications for this in terms of development of new medicines, doing whatever we can with whatever we have. Very quickly, here is the history, and you could very quickly, I need to go back on that. How do I go back on that?
Just with the arrow keys. Just use
the arrow. Yeah. Okay. Here we go. This is the history of it. And you can see that we had the concept in 1975. Very quickly, we had the realization of the concept through a list. And the second committee said, look, we are not only selection, but we need to talk about rational use. We now have the list being revised every 2 years. Essential medicines list for children in 2007. The 18th list has been released in July now after the meeting. So this is something that has gone on for more than 35 years. And sometimes I ask the audience, aren't there people who are younger than the essential medicines list? So going on to what are essential medicines? What is the concept of that? Well, first of all, a limited range of carefully selected essential medicines leads to better health care, better drug management, and lower cost. That's what we say. The next one is what is the definition of essential medicines. And what we have here again, essential medicines are those that satisfy the priority healthcare needs of the population. Note what we say, priority healthcare needs of the population. We don't say that they satisfy all the healthcare needs of the population. It's a very selected list of priority healthcare needs. And it's very difficult to give a figure, but we say maybe something between 80 to 90% of the healthcare needs of a country. Now, next one, how do we select them? You can see that the criteria there. The next one is in terms of continuity and sustainability. We have had this list going for more than 35 years, and the last one, which was just published, has 374 medicines. So a global list which says which handles the priority healthcare list needs of the world is only 374 medicines. And that's what we have focused upon. And what has it been said? Well, Medicine Sans Frontiers said the first list was a major breakthrough in the history of medicine, pharmacy, and public health. Bringing everything together. It wasn't just simply looking at diseases only, but pharmacy as well as public health. Next one. Very quickly, what is the target? And this is what we have as the target. We have all the drugs in the world. Then within a country, these are the registered medicines. Then we have at the very center for the very basic healthcare, moving out to health centers, hospitals, referral hospitals. And within this blue line is the list of essential medicines. And that's what we have in that situation. Okay, now, how do we, has this made an impact in countries? Is this something that has been there which the WHO advocates, and nothing else happens very much. Well, over 100 countries have a national essential medicines list based on the WHO EML. So clearly there has been an impact, especially in low and middle income countries. When revising national lists, WHO lists will be medicines will be taken into account, what are in the list. Next one, multilateral agencies. This is where it uses the situation of the Global Fund. Global Fund was mentioned. Whenever a country goes with an application to a Global Fund for a particular medicine, first question, is it on your national essential medicines list? No. Is it on the WHO list? No. Then can you please justify why you want this drug? If it is on the two list, no justification is needed. Donation of medicines, again, if you ask DFID or any of the bilateral donors for a medicine, is it on your essential medicines list? If so, yes. Otherwise, please justify why you want this. Now, to go back to the three themes that were asked, what have been our successes? Well, it's a universally accepted concept. It is now taken all over. Next one, it's wide adoption in low and middle income countries. Okay, part of global health. Now, I make the statement, it is an even wider implementation in high income countries. And you always say, really? When I went to my GP, did I get an essential medicine? When I was in hospital in Sussex, did I get an essential medicine or what? Well, if you define the concept as this, an official list for training, supply, reimbursement for related health objectives, can I ask the professor from Brighton, Sussex Medical School, do you allow all your prescribers to prescribe anything that is there, or is it a selected list?
We have a selected list.
You have a selected list. So you allow all the beneficiaries of the concept of essential medicines and its implementation even in Brighton and Sussex. So you can see that this list, everybody talks about it, in terms of, the essential medicines list is good for these poor countries who can't afford it and so on. But we in the high income countries can afford anything. No, they cannot. And they have the same type of list that is based on the principles. Very quickly, how robust has been the process? Well, we have declarations of interest in our report which says, all the committee members please declare. Does the Brighton formulary have declarations of interest in its report?
I don't know that detail.
Okay, right. But we have put out on the essay publicly so that if somebody has not declared an interest, that can be pointed out. So clearly, conflicts of interest are looked at in that one. Well, it is a strategy that has explicitly embedded healthcare needs and cost effectiveness in the healthcare system. Okay, now, all of that is nice. What are the challenges? A concept and a list ahead of necessary infrastructure in the low and middle income countries and ahead of political will necessary to implement it in the high income countries. Go to the low and middle income countries and ask them, you have your list. Now, what about the supply? Do you correlate the two? Not really. Can you tell us how much you spend on essential medicines and outside the list? Well, we really don't know. So that means they have the list, but they may not be implementing it. And in high-income countries, if you ask them, do you want to limit medicines that are effective in your hospitals? Not really. In the United Kingdom, no, they won't do it. But they will have mini formularies all over. You will have it at national level. Last time I counted, in the benzodiazepine section, 12 available in the country, but only 5 given in the NHS. So you limited yourself to 5, although all 12 are registered and will be exported with an export list, although 7 of them are not available in the health system of the country. It's a strategy that has explicitly embedded healthcare needs and cost effectiveness, right? Quality of medicines, as mentioned, is a major problem. Yes, our low and middle income countries have problems in the quality of medicines. Once accepted, is it strong enough to withstand influences? At the beginning, it was said, no, this is not something we want to get involved. The pharmaceutical companies did not accept the process. Now, the applications we get are from pharmaceutical companies some of the time to include their medicine in the list, because they know if it's in the list, that would mean that they will be able to get that medicine procured within that country. Problems? Do we have the expertise in the countries to adapt the national list to a WHO list to a national list? For example, do you just take the list and then cut it out and put it into the countries? Or do you really think of what you have in your countries and adapt it? Major problem in trying to do that, the technical expertise is lacking. Well, I've heard this phrase, forward guidance, which was from the Monetary Policy Committee of the Bank of England, which says this is what we are going to do for the economy. Is it a useful forward guidance for new medicines development for the pharmaceutical industry? Look, this is what we require for healthcare needs. Do we require a cancer drug which will extend life by 2 months at the end of life? Or would it be better to put the money into a medicine for Alzheimer's disease which will prevent people from getting into institutional care for 1 year? Where is your priority? At the moment, who decides the priority? Who decides the priority? It's the market. The pharmaceutical companies go ahead and say, this is the market, this is what we decide. Would society want to define that and say, this is what we need? If they so define it, can they also say what amount of money we are prepared to pay on that? After they have developed it, are you going to drive the cost down? There must be a bargain, right? Okay, so here we come on to health technology assessment. Very quickly, health technology assessment is a multidisciplinary field of policy analysis that examines medical, economic, social, ethical implications for the incremental value, diffusion and use of medical technology. And basically, does the medical technology give value for money? That's what we're asking. Last Tuesday, National Institute of Clinical Excellence said, we have this new drug which was a successor of Gleevec. Are we approving it? No, we are not approving it because there is insufficient evidence to show that although it may extend by 2 months, the cost of it is too much, therefore we will not be approving it for use in the national health system. Okay? So then, why is it becoming important now? Well, I don't need to belabor the point. Dr. Brian Tempest just said, gave you the nice slides of how healthcare costs are increasing compared to general business, right? Well, we have the National Institute of Clinical Excellence is a premier example. That's what is coming into, and in a sense, we in WHO, at least in essential medicine, say that essential medicines was the name before health technology assessment came on. Because that was what essential medicines did. We assessed what was the value of the medicine before putting it onto the list. And when we assessed it, we just didn't look at the cost of medicines, we looked at all the other aspects like what is the cost of diagnosis, what is the cost of other things, compare it with everything else. But nevertheless, we now find a very strong partner in this health technology assessment being a part in selection of essential medicines. Very quickly, what is the outlook? We think it's good. We've got a promising future. After struggling away, nothing very sexy as HIV/AIDS, nothing very sexy as this thing, working with healthcare systems in low and middle income countries to get care, we are now being told, look, we now see it being acknowledged in the high income countries that this is the way to go. Health technology assessment will be a strong partner in the future, but do we have the expertise to implement it? Same problems that we had with essential medicines. What is also going to push very, very hard is universal health coverage. It's a part of the United Nations General Assembly resolution. where we have said universal health coverage is what is going to be there. And if you have universal health coverage, what are the medicines that you're going to have as a part of the package? Well, defining what is useful for healthcare systems. Would you want forward guidance? Is it a better strategy than the market for medicines development? Will society define, coming up from these concepts, what it thinks must be necessary for development of medicines? Well, just to give you a very quick example, we have a second level drug for the treatment of bleeding, prevention of bleeding after childbirth. Why do we have it? Because the first drug isn't heat stable. And because it isn't heat stable, it cannot be used in a majority of situations in low and middle income countries. Who is going to develop the heat stable oxytocin? If that is so, then the second level drug can be taken away. But who is going to develop, who is going to do the development cost? These are questions that we have to ask. Next one. Serving healthcare needs rather than developing blockbusters. These are the issues. Final slide. This is a statement that has been made by the Director General. Discovery science makes the headlines. Delivery science saves the lives. And that's what essential medicines has been doing. We've been delivering what has been there rather than discovering anything new. Our only new discovery has been essential medicines has exploited existing medicines to deliver enormous improvements to health. In future, can essential medicines concept also guide to what the needed medicines are? Can we say this is what we require and not leave it for a market? Monica mentioned about the question of whether the excess cost model can be used. In this particular situation, it's also coming into the high-income countries where they have to decide what is the medicine they are going to take. If they decide in advance, then the pharmaceutical industry has a chance to develop what they think is appropriate. In the end, it would be advancing from influencing access to improving innovation. Thank you very much.